for joining this session. We're going to try to set a record by starting at 8:45 on the dot. We know there's going to be a plenary after that, so we'll try to manage time. Thank you very much for coming. So we're going to be starting in the next 2 minutes. In the meantime, just to give you a bit of a background, this session is broken down into like 3 subsessions. There'll be a scene setting session, so we'll have the first 2 speakers, whom, because of time, I'll invite them just before 8:45 to join me, Dr. Jess and Dr. Akudo, so they'll join the stage. And then we'll have a panel discussion that will be moderated by my colleague, Dr. Kim, and then we'll have a closing by Lillian. So we cannot start right now because, you know, the session needs to be live, and so we have like a minute. So taking this moment to welcome those who are outside to get in. This is going to be, yeah, bring people in, yeah. This is going to be a wonderful session on elimination of mother-to-child transmission. So as we get started, I just want to say that we've had very, very many sessions on EMTCT in this conference, which is really a wonderful thing, considering the fact that we are approaching the year 2030. If you look at the goals for elimination of vertical transmission of hepatitis B, HIV, syphilis, we still have some miles to cover, and we cannot do business as usual. We need to be creative, we need to be innovative, we need to listen to what the communities are telling us, and work with the governments and be more intentional about reaching the 2030 goals. Yeah, so very pleased to have you in the room. Can you confirm if we are now live so that we can start? All right, great. Thank you so much. And please load up my slides. So colleagues and friends, this session, this satellite session is about, the title is Breaking Silos for Better Care, Integrated Approaches as part of elimination of mother-to-child transmission services in Africa. It's brought to you by SAFEStart Plus project, which is led by PATH with its 2 co-leads, the International Community of Women Living with HIV in East Africa, ICWEA, big clap for them, they're sitting over here, and the World Hepatitis Alliance, WHA. SAFEStart Plus project is funded by and implemented in partnership with Unitaid, and we're so glad to have also the Unitaid team in the room. Colleagues, our biggest stakeholders are the country governments and the communities, so we really are thanking you for the work that we've started together from May 2025 up to 2029. As I mentioned a little bit, HIV, syphilis, and hepatitis B among the leading causes of preventable child mortality and stillbirths. And there are many barriers. One amongst them is how fragmented services are, how siloed is funding, programming, and also service delivery. So we are here to really explore some ways to try to address this problem. So I want to take this opportunity to thank all of you for joining this session. My name is Dr. Albert Komba. I'm the project director of SAFEStart Plus project. I work with PATH, and we have 2 other moderators whom you'll be seeing in a little while. This is going to be a brief agenda broken into 2 parts or 3 parts, as I mentioned. We'll start with the scene setting session. So I have wonderful colleagues of mine whom I'll briefly introduce. The first one on EMTCT progress in Africa, goals, guidance, and gains. And this will be delivered by Dr. Akudo. And then EMTCT as an enabler of integrated services by Dr. Jess. And then after that, we'll have a roundtable discussion Kim will give an introduction to. So without any further ado, we're going to start with the first session, and I have the great pleasure to introduce and welcome Dr. Akudo, who is the team lead, TB, HIV, hepatitis B, syphilis at WHO Afro, who will be taking us through the first part of the presentation. Welcome, Dr. Akudo. Some few things to highlight. There are some codes, QR codes on your tables for translation if you need any. And then you're not going to see me again. Akudo, welcome Jess, Kim, and then we shall move on. Big clap to Dr. Akudo.
Thank you so much, Albert, and good morning, colleagues. It's always great to be able to talk about PMTCT. Can I have the... Yes. It's always great to talk about elimination of vertical transmission. And in the 5 minutes that I have, is that an echo? Okay. In the 5 minutes I have, I would quickly go over the goals, the guidance that directs our work, and the gains that we have made so far. So I would attempt to fly. Is somebody moving this on? Okay, great, thank you. So the overarching goal is built on the global commitment to triple elimination of vertical transmission of these 3 diseases. As many of us know, WHO has defined the criteria for the ultimate goal of elimination, which is achieving and maintaining 95% coverage, maternal coverage of services, and achieving an infant case rate of less than 50 per 100,000 live births, with a transmission rate below 5%, and this is for HIV. Time will not permit me to unbundle the details for each of the diseases, including the process and the impact targets. However, I will just talk about the path to elimination, which is where we sort of see many countries in the region because of the high burden within the region. And so there's a framework for the path to elimination, which was put in place to recognize and encourage progress by countries in high burden settings. The PTE framework, it allows countries to be certified at either bronze, silver, or gold tiers based on their performance. And as you can see, the targets become progressively more stringent as you go from bronze to gold. For bronze, it requires a 90% service coverage and an infant case rate below 750 per 100,000 live births. And by the time a country reaches gold, it must have achieved up to 95% maternal coverage and reduced infant case rates to below 250 per 100,000 live births. These, in summary, are the graded goals that countries can aspire to as they look towards full elimination. One country, we're happy to say, the Maldives, has been the first country to achieve full triple elimination across the 3 diseases, and that's a major landmark. But just note that when countries achieve this, there's also an imperative to maintain the achievement. So where are we? My clicker is not clicking.
It's up now. No, go back one. I think it's just delayed. So sorry. Yes, you got it. Okay,
great. So where are we in the region? So the data definitely tells a story of contrast. In ESA, East and Southern Africa, we see significant progress. The number of children newly infected with HIV has dropped dramatically since 2010. This success is mirrored in the 51% reduction in congenital syphilis cases, and this is driven by successful scale-up, maybe, of testing and treatment in ANC. However, for Western Central Africa, the situation is quite concerning. While HIV infections in children have decreased, we're still facing a major setback with over a 60% increase in congenital syphilis. And this is quite concerning because this is syphilis is a disease, if I would say, an infection that is old, for which we were always able to do stuff about. So it's concerning that there's a bit of retrogression in that area. And we think that perhaps limited testing and coverage of treatment, especially in ANC settings, has created this gap. And then going further to look at the hepatitis B situation, I've just highlighted only birth dose because that's an essential element for elimination. For birth dose, it's also we've not done very well. Only 18% of infants in the region receive birth dose, and only 17 countries have this being provided as part of their routine immunization program. I know that many countries have adopted, and it's there in their guidance, but the implementation is a totally different thing, and that's really another area where we need to pay a lot of attention. So what do we have in terms of guidance? There's, for vertical transmission, there's really a comprehensive set of documents and strategies from WHO, starting from the overall health sector strategies for 2030 to specific guidance on preventing and treating hepatitis B and more details around testing. There are changes in terms of more decentralized approaches in the new guidance for hepatitis B, and all of these you can find in the WHO website. But I will just quickly mention the new framework for implementation and for triple elimination implementation. That framework, it's really taking together a lot of what we've already been doing, what we already know, and put it together into a framework that highlights the importance of integration, and I think that's the most important point to note. Pushing for an integrated approach. Now, what are the gains? There's movement in terms of, forward movement in terms of, growing adoption of very important guidance, especially as it relates to DTG for ART as first line, oral PrEP in many countries, and now we're moving more towards injectables, towards lenacapavir. Many countries are now using the dual HIV syphilis tests, and birth dose, we're working to see how much more we can do in that area. And overall, what we can say for the PTE, where we are at, since the establishment of PTE in 2017, we've got 2 countries which we continue to talk about, Botswana and Namibia, that have made progress. But most important to note is the fact that many other countries are now beginning to show interest and to apply and to, work towards the application for validation. So I would end here by just saying that we've made progress, but not nearly as much progress as we need. We need to pay more attention to what's happening in West and Central Africa, and we need to pay more attention to what's happening with hepatitis B, testing, prevention, and care for pregnant women. And we need to, of course, make the necessary investments that are required to get us to our destination. Thank you. And it's my pleasure now to invite Jess.
I'm Jess Burry, and I'm a technical officer at Unitaid, and I'm going to see if I can find some slides. Cool. So really a pleasure to join you here today to talk about elimination of vertical transmission and how we can use that as a jumping off point if we want to integrate more services. So there's a broad portfolio at Unitaid of work being done on maternal child health and on HIV, hepatitis. And this particular project is quite interesting in that it's the elimination of vertical transmission of HIV, hepatitis B, and syphilis. And then just as the ink was still wet, perhaps on the papers, as we finished that grant together with PATH, we added in mpox as well. So we'll talk a little bit more about that. And this particular project that is led by PATH, together with ICWEA and the World Hep Alliance, is the SAFEStart Plus project. And this is about community and country-led scale-up of accessible, integrated, and family-centered EVT services for a healthy start. That's a long title, so we just go with SAFEStart Plus. And what's actually really interesting about this project is that more and more we're seeing, and especially in the past year with the difficulties and the funding challenges, that it's becoming really quite important that as Unitaid, our projects and our investments are done together with our implementing partners, but also in co-creation with countries. We need to be aligned with country strategies and to make sure that this is going to be sustainable investments and that countries are able to look at this as a longer term part of their plans. And this particular project is even more exciting because for many years we've been doing a lot of work around communities and funding communities and allowing that work to be leading the way. And in this particular project, I think it's the first time for Unitaid, if I'm not wrong, that we've had co-leads from communities. And so the point is that it's not just ticking the box. It's about really having communities leading the way, and that it's around having them part of the governance. And in this case, we have ICWEA and World Hep Alliance, who are both represented in communities living with hepatitis and HIV, and that they're really making sure that their needs are at the front of the interventions and part of this in a sustainable way. And so I'm really pleased to see how this project will develop. It's just started in May, and so it's continuing on until 2029. And we'll talk a little bit more about it. This is just to give you an idea of the countries where you'll see some of this work coming up over the next few years. And so in this 4 countries, the 4 core countries are Nigeria, Uganda, Malawi, and Paraguay, and they'll get sort of a full package. And then there's 5 focus countries, and they'll get, depending on the needs in those countries, interventions based on what they need. And then there's even more countries where we can have a targeted approach in terms of disseminating information and supporting that countries can also implement SAFEStart Plus. So I'm not going to read all of these bits of work to you, but the idea here is that there are 4 original outputs, or 4 sort of buckets of work in this PATH project around, demand, adoption, market shaping, supporting countries, and then as I mentioned earlier, we were sort of watching the whole time we were developing this whole project and saying, in the Afro region, we have a small problem called mpox, and at the moment, when we were working through this whole thing, we couldn't really do much about it. We still didn't have diagnostics, we still don't have treatment, but we were sort of watching to see what we could do and how we could support. And then eventually we came across a diagnostic product that we think looks interesting, and so that became a point where we could say, actually, this project is perfect in the sense that it's already in the ANC clinics, it's targeting HIV populations and testing for HIV, and those are the people that we knew, and we're seeing more and more data showing that they were the people at risk of poor outcomes if they get mpox, and so how can we do more? So we added in an extra bucket of work because they didn't have enough to do already. So we added in one more piece, and this also falls in line with Unitaid's pragmatic priorities. So we do a lot of work on HIV, TB, malaria, women and child's health, but we also have a piece of work to respond to global health emergencies. And so this was actually a concrete way that we could support our projects and support the people in those countries. And so we've added in a piece on mpox in DRC specifically, and also in Sierra Leone through another project that we have with ORAM, and looking at how we can bring in diagnostics, decentralized diagnostics, link people to care. We know that even if we don't have an actual treatment option, we know that people do better when they have linkage to care, and to support on things like data collection, on IPC, infection and prevention control, and to look at how we can also implement the WHO guidance on reflex testing for mpox and HIV. So still lots of work to be done. This is really the beginning for the mpox component of the EVT, but we see this as really an opportunity. And then the other piece that we're interested to look at is how we could possibly use these platforms and ANC clinics as a point to add lenacapavir. And so that's like the hot topic, and I'm not going to go too much more into it today. Everybody is trying to figure out how we can get lenacapavir, where to put it, and what's the best option. And of course, ANC clinics is a no-brainer, and I hope that we can see. Let's cross our fingers for this project, but in general, we'd like to see more and more countries getting ready to roll out in the coming months. So I'm going to stop there. I'm going to hand over to Kim, who's going to bring us to the next part of the day, of the morning. Thank you.
Thank you so much to Dr. Jess, Dr. Okudo, and Dr. Albert. We're so grateful for framing the session on integration and moving from siloed to integrated people-centered care. So with that, we're going to move to a panel discussion. Here we're really going to bring to life some of the interesting examples and challenges related to integration. particularly which, as we know, have been accelerated by the dramatic shifts that have happened starting in January of this year with significant reductions in funding for global health. My name is Dr. Kimberly Green. I lead PASS program in primary healthcare, which focuses very much on integrated services and systems. So with that, it is my pleasure to introduce our panelists. So please come to the stage. Rejoice Mary Abba, who is a project officer with the International Community of Women Living with HIV West Africa. Welcome. Next, Dr. Izukanji Sikazwe, who is the head of HIV for the Global Fund. Welcome. Next, I'd like to welcome Dr. Stephen Ayisiado, who is a senior public health physician specialist, yes, of the Ghana Health Service. Welcome. We had to have Ghana represented on our panel, being hosted so warmly by Ghana for this conference. And then Dr. Mojisola Mobalaji Bello, who is the Global Fund grant lead with the National AIDS Viral Hepatitis STI Control Program in Nigeria. So welcome to all of you. Hear from you in terms of the role that the community and peers are playing in terms of fostering greater integration before the changes in January and certainly now as part of what's happening, and what support that you need in thinking about integrated care for pregnant women, breastfeeding women, their infants and partners. What better support do you need to play your role fully from governments and from donors? So over to you.
Okay, hello, good morning. Okay, thank you very much, Kim, and good morning, ladies and gentlemen.
Good morning.
Thank you. So, the role of the peer networks and grassroots organizations in shaping demand for integrated service for pregnant women. I'm going to start with bridging knowledge gaps among women and girls themselves. For me, this is key and a starting point because it's the only when women and girls are aware about services that are available, will they be able to access those services. They'll be able to, so it is the responsibility of the grassroots organizations and peer networks to ensure that women and girls, especially those at the grassroots, are aware about available services for pregnant women and girls. Most especially because most of these women at the grassroots are unaware about available services in these regards or unwilling to access them due to cultural barriers and all. There's a need for awareness about the importance of antenatal care, skilled safe delivery procedures, identification of danger signs in pregnancy, and available health services, especially for women and girls living with HIV. This will be achieved through community-based education campaigns and peer support groups, which is very effective because it uses locally adapted materials and native languages, as well as addressing low literacy levels. So peer networks and grassroots organizations have been doing this and are still doing this, and women are getting to understand and access EMTCT and other SRHR services, even though there are still knowledge gaps and we still need to keep working. The other one is advocacy and accountability. Grassroots organizations can mobilize communities to advocate for better services and hold local health authorities accountable for the quality and availability of maternal health care, leading to improved infrastructure and policies. This ICW West Africa, ICW East Africa have been mobilized, have been into advocacy, and other organizations as well, to advocate for access to non-discriminatory services for pregnant women, especially those living with HIV. And over the years, we've made a lot of progress, and we have a lot of success stories. Also, of enhancing accessibility. Grassroots organizations can also help to address practical barriers like lack of transportation of funds to access healthcare services. They can establish emergency transport funds or link women with available resources. directly enabling access to facilities for checkups and delivery. Building trust and overcoming cultural barriers is one of them as well. We still have communities with strong beliefs and dependency on traditional practices and a mistrust of formal health system, especially in Africa, and community health workers, but instead respected local figures such as traditional birth attendants, religious leaders, and etc. The role of the peer network and grassroots organization in this regard is to facilitate dialogues and encourage a blend of traditional and modern health care and making facility-based care more culturally acceptable. So strengthening collaboration with traditional birth attendants is key, as TBAs remain key actors in many communities, especially at the grassroots levels. Many pregnant women, particularly in rural areas, still rely heavily on traditional birth attendants based on trust. Over the years, grassroots organizations have ensured that training of TBAs on early referral, danger signs in pregnancies, respectful care, HIV testing and linkages, EMTCT, and the importance of the use of facility. In addition, providing emotional and social support. Young pregnant women and girls, such as the adolescents, often face discrimination or lack family support. Peer networks have provided a safe space for sharing experiences and offer emotional assurances, which reinforces positive health-seeking behaviors and help counter misinformation and stigma. On how the government could come in and support this cause, government can make this more effective by providing reliable and flexible funding for organizations. They could be able to offer direct financial support through grants that are less bureaucratic than traditional government funding, allowing for innovative community-led approaches and operational adaptability. Our government and donors should please take note of this very important aspect. We need funding most times to create that change that we envision. We also need the government to integrate efforts into official health systems. Instead of running parallel programs, government should formally collaborate with and integrate community-based interventions into existing national health plans and referral systems. Capacity building and training is another one. They should support the training and supervision of community health workers, which are midwives and peer educators, to ensure they provide accurate and high-quality information and care, thus increasing their credibility and effectiveness. Fostering an enabling policy environment is another one. They should develop policies that recognize and legitimate the role of peer networks and grassroots organizations in healthcare delivery. This includes involving them in planning, implementation, and monitoring of maternal health programs. So I want to conclude by saying that much has been done and much is still required to be done, so we keep working. Thank you.
Thank you so much, Rejoice. That was so excellent. You very clearly outlined the critical, fundamental role. Yes, please, 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 and applaud. The critical role of the community from the very start, across advocacy, awareness building, access to services, and bridging between traditional medicine and facility-based care. And you also called for governments to invest better in communities, make it more simple, and to work with you as partners from the very beginning. So I think, yeah, all really critically important. So with that, I would like to turn to a major funder of community-based organizations, to the Global Fund. So Dr. Izukanji, the Global Fund has long invested in HIV EMTCT services, and more recently has moved forward to include triple elimination, so elimination of HIV, syphilis, and hepatitis B as part of your funding. Please tell us more about what opportunities there are, including for the community groups that are here, on making sure that integrated services across these 3 diseases are available and as part of routine antenatal care through primary health care in the countries where they live. So over to you, thank you. And please keep to 4 minutes. I'm so sorry, we're so tight on time. If it's not working. Yeah,
okay, good. Yeah, now I'll keep to time. Thank you so much for having me here. I think, let me put back my clinician hat on and say that we've been laser focused on HIV and made tremendous progress there. But we have increasing epidemic of syphilis as well as hepatitis B in our population. We saw from the WHO presentation how we've not made significant progress there. And it's going to take a whole sector approach. It cannot just be the donors or government or community, but across the partnership, including pharma, for diagnostics as well as treatment. So we use that framing, I think, to remind us that there's a lot more that needs to be done around hepatitis B and syphilis. And while we celebrate the gains that we made with HIV, we've forgotten about Hep B and syphilis. So the Global Fund has really put a lot of investments around triple elimination through our grant cycle 7. And you'd see that the funding amount has increased through grant cycle 7 to address all 3 diseases. And this continues through the upcoming grant cycle 8. So we supported about 104 countries with HIV funding during grant cycle 7, but 69 of these were prioritized for triple elimination. And we've included interventions and policies that are supportive of community initiatives and really using the integrated approach because siloed interventions are not going to work, so really looking at integrated approaches. And if you look at our guidance for grant cycle 8, it emphasizes integrated systems. It's front and center. It emphasizes community engagement. So we're using that framing to make sure that we do more for triple elimination. And with the current funding that we have, we've seen increased procurement for geotesting, which is remarkable. A good number of countries have come together using our pooled procurement mechanism to be able to harness lower costs for geotesting. And so that's something that we're really proud of. In grant cycle 8 guidance, you will see that triple elimination is a program essential, as well as screening for STIs in pregnant and breastfeeding women. That's a program essential. So again, guidance is really clear, and I think it emphasizes the importance of triple elimination. I know we're out of time, but again, to say that it's not possible for us to hand over to governments and say governments take these programs on when there is increasing incidence of syphilis and hepatitis B. We have to be able to hand over programs that are in a decline and can be sustainably maintained going forward. Yeah. Thank you.
Thank you so much for those, very powerful remarks, Dr. Izukanji, and the power of integration and the very strong leadership that the Global Fund is taking, including through your leadership, on putting integration front and center, and really looking forward to partnering with governments and communities to practically support the enablement of integration. So I know there's more to come on GC8. We're starting next year with applications, but it's very clear, this message here, that there's a strong funding opportunity and prioritization of triple elimination as part of integration. And so we strongly encourage all of you in the room who are involved in Global Fund and CCMs and as advocates to support application for triple elimination where there's a need for that. Thank you. So now I'd like to turn to Ministry of Health representative, to Dr. Stephen Addo. Ghana has a deeply impressive track record of strategic domestic financing for health, inclusive of HIV, as part of your national health insurance system and also as part of your emergency fund, the Mahama Fund, and much more. So tell us more about the progress that is made in financing EMTCT for HIV, as well as syphilis and hepatitis B, and what more needs to be done to ensure that across the board, all 3 diseases are financed through the government so that individuals, pregnant women and their newborns can access those services without financial burden.
Okay, thank you very much, Kim, and a very good morning to all of us. So as you heard in the plenary session, I mean, the things you said were affirmed by the Vice President, Her Excellency Jenana Pukwajiman, the Mahama Cares, the NHI. But proud to even the National Health Insurance, there had been a process to try and get government to take care of elimination of mother-to-child transmission. That's catering for the need of the program. And we have started a process of integrating EMTCT within maternal, neonatal, child, and adolescent health services. So if you take from the beginning, implementation to data collection, we had integrated tools, and we were leveraging resources from MNCH, Family Health Division, to cover some of these, because it was not only the Global Fund, sometimes Global Fund funds some of those processes, but once the Family Health Division also was taking care and everything was integrated, the opportunity was there for things to progress. And that's why we made a lot of progress. So with respect to the human resource, capacity building, that integration with the family health program made it possible for us to take advantage of other resources aside the Global Fund to take care of the needs. Now, going forward, through the Resilient Sustainable Systems for Health model of the Global Fund, which more or less was trying to prepare us for greater domestic financing, that model makes it possible for the health system to be strengthened for the 3 programs, including HIV. And it takes care of the broad issues of human resource, the logistics, management information system, the data issues. And through that, we had even launched the e-learning opportunity for capacity building and all that. And that, once it's been established, will be taken care of by government, even when Global Fund resources don't come in. We are all aware of the cuts in funding. And so hopefully, with National Health Insurance, you are able to access services wherever you are. And then when it comes to commodities, government is co-financing, government is paying for. In fact, in some of the years, it's government that pays for test kits. All right, so and that is part of budget, and therefore we need to make available to government the needs of the country, and that is factored in budget, and then it is provided for as part of our co-financing obligation. Now, currently and going forward, as we've all heard, there's been the uncapping of the National Health Insurance. And uncapping means that there's a removal of the limits of the amount of money available, and therefore more money is supposed to be available to cater for the needs of all of these. Now, it's not going to be only for HIV. They're looking at all other Gavi, EPI, everything, everybody's interested. But we need to continue to push the advocates to make sure that HIV needs on elimination of mother-to-child transmission is not left out. By all means, there will be a competition, but we must continue the engagement with government with the data, because the progress we've made is a good example to motivate everybody. Given our coverage is beyond 95% now, but I think we need to be able to project that strongly and to say that if we continue to chip in more and government prioritizes the needs of the children, the mother-baby pair, within the context of maternal, child, adolescent health, which is one of the major priorities of every government, I think we'll be able to, achieve elimination. Thank you very much.
Thank you so much, Dr. Addo. We need examples of how governments are increasingly financing EMTCT as part of overall domestic financing and universal health coverage. So really, for us, it's important to see the example and learn from what Ghana is doing. And I think that nice partnership with the Global Fund and that transition and learning from the investment of the Global Fund and then the government progressively picking it up is exactly what we want to see. So thank you for that. I'd like to turn now to another powerhouse in terms of domestic financing, to Nigeria. So I'd like to turn to you, Dr. Mojisola. So in light of the evolving financing in global health, and at the same time, Nigeria's very strong leadership and response in ensuring that there is the financing in place for healthcare in Nigeria. Tell us more about what's happening with financing specifically for EMTCT, for HIV, syphilis, and hepatitis B, and how that's fitting within the overall reforms for primary healthcare. Thank you.
Thank you very much, and good morning, everyone. So I think it's an opportunity to share that most of the WHO recommendations is what we have put in place in country. And just before the global health finance shift, we were already leveraging existing systems. It's just that our system being leveraged is a bit different from Ghana, that is maternal and child health. We were leveraging the HIV funding, and we had put systems in place, policies, the data collection tools, the reporting systems, the training slides, the capacity for the healthcare worker. We had already leveraged existing resources, and we're already trying to integrate our systems. And I think that is one of the things that gave us the leverage that even in GC7, we were able to get funding for triple elimination under the Global Fund grant. So when it was time to approach, the major gap was just commodities. All the other systems were already in place, and it was easy to. However, with this good news, the effects of the pause affected a bit. Sometimes early in the year, where we had pause in commodities coming in. And by the way, we had already adopted dual syphilis HIV kits in country. And so, of course, once the HIV is affected, the syphilis is also affected. Remember, we're leveraging the HIV systems. So it affected us quite a bit, but we're able to pick up eventually, even though there was a bit of, it affected our performance. So sometimes last year, where we're doing almost 70%, we saw for the first half of year, dropped to about 53% testing across, particularly the HIV syphilis, whereas hepatitis is just peaking. And the opportunity to also share that for the first time in country, we're able to procure and distribute over 2,000 HIV test kits for our pregnant women. It's also from the Global Fund. And so the push for integration, I think, is one of the strategies that we're pushing in country, and not just integration, involving also the subnational government. The national government has signed pacts with the subnational, where not just the national government bears the burden of health. Health in Nigeria is on the concurrent list, where the state government also have their responsibilities. So whilst the federal government is coming in with some resources, the state is also asked to also contribute or make their own impacts. And we've seen across the states, quite a lot of them have made commitment, particularly to triple elimination, because when we started with the triple elimination, it was, we knew we had to leverage on domestic financing. And so from inception, we were already engaging the leadership at the subnationals, for the commitments, and we're beginning to receive that. But from the national space, particularly with the PHCs, you're aware of what the current minister, the efforts of the current minister, and it's not targeted at any specific disease, right? So we're saying integrate and health systems strengthening, engaging healthcare worker, building their capacity to provide integrated services, unlike the previous siloed programming that we had in country. That's one of the strategies. Also procuring commodities. We're trying to establish systems for pooled procurement. And so across all, all the blocks, engaging the community, establishing, we had a system of community engagement before, community healthcare workers, which we're trying to revamp as a country right now, because from the, just in 30 seconds, sorry about that, from the start of the PMTCT, we're no longer sitting in the health facility, we're going beyond. It's no gainsaying that Nigeria's over 30% of our women do not come to the health facility. So the whole system is what we're looking at right now, and the language is health systems strengthening and integration, and that's the direction of the country. Thank you.
Thank you, Dr. Mojisola. That's a really inspiring way to wrap up our panel. That's the strong movement to integrated primary health care, inclusive of EMTCT, and the focus on the community, extending services into the community to ensure that everyone has access. So thank you so much for all of our brilliant panelists. Thank you so much to Dr. Izukanji. Thank you so much for Rejoice, and thank you, Dr. Stephen. Brilliant remarks, very inspiring. Obviously, there is much more to do, but I think it gives us a sense of the potential and the optimism moving forward. So please give our panelists a very warm round of appreciation. And with that, I'd like to turn to Lillian Moreco, who, as many of you know, is the phenomenal leader of ICWEA and is going to be wrapping us up with a call to action.
Thank you very much to our panelists, our facilitators, and to all of you in the room. I would just wrap it up by saying 1, 2, 3 things that we've heard that we must break silos to eliminate diseases, barriers to access, and utilization of services. We've heard that since we started this session. And we've also heard that integration is going to require that we integrate services, systems, procurements, resources, but importantly, partnerships. And that we need flexible funding for community-led responses to be able to support our governments to deliver services to their people. So basically that's what we've heard, and to make sure that we are within time, I would like to say on behalf of the SAFEStart project team, that is a partnership, would like to say thank you to Unitaid for the support, for believing in communities, and for supporting this partnership, to PATH for partnering with communities. And it is a call to action to all of you here who are implementing programs that believe work with communities. That's the only way we are going to eliminate diseases. That's the only way we are going to end AIDS by 2030. But also to ICASA leadership for giving us this platform today to give visibility to ending triple elimination, particularly for children who cannot speak for themselves. So we are here to speak for the children. And to our governments and ministries of health, we appreciate you, and we are really happy that you're taking on this role seriously and engaging with us. To WHO, thank you. To Global Fund, thank you for believing in communities, and as we get into integration and as we get to reduce resources for communities, we hope that you are going to stand up again and show that it is important to have communities with you, but also that they need to be funded to be able to do the work that we need to do and we need to end. And to all communities, wherever you are and the work that you do, it is well appreciated. And I think one key word for me that has stood out is that we must make sure that we are integrating, but we are also looking at family-centered approaches to ending the epidemic. And therefore, that is one of the calls to action to all of us. And once again, thank you very much for being with us this morning, very early in the morning. That shows that you're committed to this work. But also importantly, and what I want you to take from what Rejoice said, we are the advocates for children. There is no child in this room, and therefore, us being here, we are speaking and we are working on behalf of the children who cannot be here. So thank you very much.